Hello viewers, we are going to discuss retinal detachment here. This is a very, very common phenomenon, and it is one of the most widely encountered eye emergencies that you're going to see in the ER, or even if you're working as a primary physician in an urgent care setting. So you should be very familiar with this, especially how to diagnose it, not necessarily how to treat it, because it's going to require a referral to ophthalmology, and an ophthalmologic specialist is going to be the one that treats it, but you are going to be responsible for diagnosing it. So retinal detachment is a separation of the retina from the retinal pigment epithelium. So you could consider the retinal pigment epithelium to be part of the retina, but when I'm referring to the retina here, I'm referring to the sensory retina. So the nerve layers that, including the rods and cones, that process the image and then send it down the optic nerve. The retinal pigment epithelium is a thin layer that sits between the sensory retina and the choroid, which is really the supportive structure interior to the retina. Or exterior to the retina. So it's a separation of the retina from the retinal pigment epithelium. About 1 in 300 people will develop retinal detachment at some point in their life, and that incidence will increase with age. So the older the patient is, the more likely they are to have retinal detachment. It's more common in the older age groups. Other risk factors, in addition to age, include myopia. So I'm not exactly sure why myopia is associated with retinal detachment, but it most certainly is. My guess would be that with myopia, the eye is typically a little bit more elongated, and so that might stretch the retina out and make it a little weaker. But I'm not sure on that. But myopia is certainly associated with retinal detachment. And the worse your myopia is, the stronger prescription you require in your glasses or contact lenses, the likely you are to develop retinal detachment. And usually when younger patients come in with retinal detachment, typically they're nearsighted. They have myopia. Previous cataract surgery increases your risk because with cataract surgery there is an intraocular lens that's placed, a synthetic lens, and that increases your risk. Aphakia, so the presence of no lens at all, that increases your risk. Ocular trauma, and the trauma here, we're not talking about necessarily getting punched in the face so much as, or getting stabbed in the eye, so much as we're talking about trauma from acceleration, deceleration injuries. So remember that your retina is attached to other tissue, and with acceleration, deceleration injuries, you can get tearing of tissues. That's why with acceleration, deceleration injuries, you can get tearing of your aorta. Smoking is associated with retinal detachment, both first-hand and second-hand smoking. Diabetic retinopathy and HIV retinopathy, both of those weaken the retina. Like I said, most commonly this is seen in older patients, 40 to 70 years of age. And rapid diagnosis is critical. It means the difference between visual preservation, which typically retinal detachment, if diagnosed early, comes with very good prognosis. But if it's not diagnosed early enough, it can lead to total blindness in the affected eye. So just to briefly recap the ocular anatomy, so this is the retina here, and the retinal pigment epithelium is not labeled, but it would be right in between the retina and the choroid. So the choroid is this pink layer, and the retina is this orange layer here. All right, and so I also want to point out the vitreous humor. That's going to play a role in one of the mechanisms of how you can develop retinal detachment. So there are 3 different ways you can develop retinal detachment. The most common is rhegmatogenous retinal detachment, but there are 2 other ways you can develop it. So there's exudative or serous retinal detachment, and what this is an accumulation of either serous or hemorrhagic fluid in the subretinal space. So in between the sensory retina and the retinal pigment epithelium. and that's due to hydrostatic factors or acute inflammation. So severe hypertension, central retinal vein occlusion, neoplasial effusion, all of those would lead to hydrostatic force of fluid out of the arteries. Then there's tractional retinal detachment, and this requires some kind of a scar on the retina, and that results in centripetal mechanical forces that can then tear the retina from the scar, or at the point of the scar. So this can be due to past inflammatory processes, diabetic retinopathy, trauma or injury, past surgery, retinopathy of prematurity, and pretty much anything that can give you a scar on your retina. Rhegmatogenous retinal detachment is the most common form, and what this is it's due to a posterior vitreous detachment. So what is a posterior vitreous detachment? A lot of people have posterior vitreous detachments and they don't know. So what this is the pathophysiology of it is, so you've got this vitreous fluid, right? And it's not exactly fluid as much as it's gelatinous. It's like jello. And over time, as you get older, it begins to become more liquid-like, so more like water rather than jello. And that vitreous is what's really holding that retina up against the choroid. And so it's really important that that vitreous stays in its normal form. But with age, the vitreous does become more liquefied, and that puts a risk for developing a tear in the retina. And when you get a tear in the retina, you the fluid from the vitreous can then enter into the space in between the retina and the RPE, and that results in detachment. Okay, so hopefully that makes sense. All right, so posterior vitreous detachment is typically asymptomatic until you develop retinal detachment. Usually the only symptoms a patient with posterior vitreous detachment has is those floaters that you can get, but otherwise it's asymptomatic. There's no pain, there's no loss of vision, but floaters are associated with posterior vitreous detachment, among other things. So the patient with retinal detachment typically presents with an acute peripheral loss of vision, and by peripheral I don't mean lateral, I mean just anything in the eye that you see that's not central, that's not what you're focusing on. So if you focus on the screen and you look at, say, this H right here, everything around it, most of the stuff around it is your peripheral vision. What you're focusing on is your central vision. So this starts as an acute peripheral loss of vision in the affected eye. A lot of times a patient will describe the peripheral vision, the area of loss, as cloudy or curtain-like. The acuity can be preserved provided that the macula is not detached. So if you ask them to read something, a patient with early retinal detachment, provided it's not affecting the macula, will be able to read. They will not have a defect in acuity. But once the macula becomes detached, then the acuity begins to deteriorate, and they start to have blurry vision as opposed to just cloudy peripheral vision. So history is also important with retinal detachment because you want to assess the patient for risk factors. A lot of people have diabetes, uncontrolled diabetes. That's certainly a risk factor. The age you'll already have on the patient, but that's important too. History of trauma, car accidents, acceleration, deceleration injury. Have they ever had cataract surgery? Do they have any other ophthalmologic conditions, especially myopia? And do they have a family history of retinal detachment? There is associations within families. Also, you want to know how long have the symptoms been present. That's going to dictate how quickly they get surgery. sometimes no matter what, they're going to get surgery within at least, at the most, a couple days. But if this has been going on for a while, they're going to need to get surgery sooner rather than later. And then how quickly have the symptoms progressed? Both of these questions are going to help the ophthalmologist determine when they want to do the surgery. The symptoms of retinal detachment are photopsia, that's irregular flashing of lights, a sensation of flashing lights, and that's caused from stimulation of the retina as it detaches from the RPE. As we mentioned, decreased peripheral vision, floaters, that's associated with posterior vitreous detachment, photophobia, and there may be a change in acuity. If there is, it's likely that the macula has been detached. So you should check the patient's visual acuity using a Snellen chart, do a visual field exam, and determine which visual fields are affected. An external exam, certainly, of the eye is warranted for any kind of trauma. And then you should also do a pupillary response test. And what you're looking for is the relevant afferent pupillary defect. And that is also called the Marcus gun pupil. What you're doing is you're shining a light in the affected eye and looking at the other eye to see if it's constricting. So when you shine the light in the patient's affected eye, if the other eye is not constricting, then that's considered a Marcus gun pupil. Both eyes should constrict if a light is shined, even if it's just in one eye. Patients who are suspected of retinal detachment warrant immediate referral to an ophthalmologist. So this is kind of a simplified illustration of what a patient with retinal detachment or retinal tears would experience. So where you're focusing in on this golfer, you can see that fine, but the peripheral vision around it is affected. So it's like tunnel vision almost. For diagnosis, the best test is going to be indirect ophthalmoscopy. So this is not something you're going to do. You can't diagnose retinal detachment from a handheld ophthalmoscope alone. So this needs to be performed by an ophthalmologist or somebody who's trained in doing the fundoscopic exam. The eye will need to be dilated. On visualization, when you look at the retina, the detached portion will appear gray and cloudy. Sometimes you'll be able to visualize the tear, and in some cases there will be hemorrhage into the vitreous. The superior temporal quadrant is the most commonly affected, so that's where you're going to want to look first. So here is a retinal detachment. This is called a bullous retinal detachment. It kind of looks like brain. It doesn't always look like this, but this is the superior temporal area. This is the right eye. And you can see it's getting really close to the macula. So this is a patient that's going to need surgery quickly, because if the macula becomes involved, their chances of their chances of recovering normal vision is very slim. So this looks a little bit more cloudy as described. Can't really see the macula here, but here's the optic disc. You can see there's some hemorrhaging here. Here's a retinal detachment that shows the tear. Here's another one. This is another bullous detachment, and this one again is getting close to the macula. Apparently it's actually affected the macula, but I only see it here, so. Oh no, it's right there. Okay, so this actually has affected the macula. Here's another one. So you kind of see that cloudy appearance that doesn't look like the rest of the retina, and it progresses from the outside inward towards the macula. And that's why it's a peripheral loss of vision. So as mentioned, you'll want to do indirect ophthalmoscopy. I can't say that word. That's generally done by the ophthalmologist. Um, some patients, however, can't tolerate the light from the ophthalmoscope. So in these patients, ocular ultrasound is performed. And this can actually be performed by somebody who's not an ophthalmologist. So they're training more and more emergency professionals to do these ultrasounds. And if you become good at it, you can actually be able to visualize the detachment. But the problem with any ultrasound is that its efficacy in diagnosing diagnosing any kind of pathologic process is operator dependent. So it needs to be performed by a trained clinician. If you're not trained, then it may be difficult. Orbital CT or MRI are other options for patients who can't tolerate the light. The treatment is urgent surgery to reattach the retina to the underlying tissue, and there are several techniques to achieve this. Scleral buckling is probably the most commonly performed. However, you can directly manipulate the retina to reattach it, but the details are not relevant for the USMLE or the primary physician because this is a very technical surgery that's performed by the eye specialist. So here's an ultrasound of a normal eye. I highly doubt you're going to get any question like this on the test, but this is just for informational purposes. So you can see you got your anterior chamber here, your posterior chamber, your lens. You can't see the lens, but you can see kind of the shape of where the lens is. And then your vitreous chamber, and the retina is, you can't really see it because it's attached to the RPE, which is attached to the choroid. And so you just see a layer here. Now when the retina becomes detached, you see detachment here. Here's another one. So here's the detachment. Okay. So the postoperative outcome, approximately 80% of retinal reattachment surgeries are successful on the first attempt. 10% of patients will require additional procedures, and the remaining will be unsuccessful. Most patients have an excellent prognosis and reattain their pre-detachment vision, provided that the macula is not involved. If the macula is involved, then the prognosis is really not very good. 25% of patients with retinal detachment will develop a retinal detachment in the other eye at some point in their lives. If you note hemorrhaging in the eye when you do the ophthalmoscopic exam, then that risk goes up to 60 to 80%. So it's a very significant risk if there is hemorrhaging, and so it's important to note whether or not that's present. I just wanted to briefly recap some differential for retinal detachment. So I didn't make a slide for this, but you can take the notes down. So some of the other things that can cause acute loss of vision would be a TIA, but typically that's episodic, and you're not going to see any abnormalities in on ophthalmoscopic exam. An optic nerve disorder is usually optic neuritis. With that, the vision loss is usually central. You'll have decreased acuity, and you'll most certainly note a Marcus gun pupil. With migraines, you can develop a decrease in vision or visual changes, but that's associated with a headache, and usually that's bilateral. And then there's other things, central retinal vein occlusions, central retinal artery occlusions, but those will look differently on ophthalmoscopic exam. I can finally say that word now. It took me a while. All right, so there are a couple men here that had retinal detachment. The first one is Mr. Pulitzer. He's the guy that they named the Pulitzer Prize after, that they give to journalists. And this is Teddy Roosevelt, who was the 26th President of the United States. He went blind later on in his life, and The speculation is that he had retinal detachment. Unfortunately, both of these men were not alive when we actually had treatment for retinal detachment. So you could have diagnosed them all day long. There wouldn't have been anything you could do for them. So if you have any questions, feel free to let me know.